So before I start, I'm going to be giving some narration kind of through some parts of this presentation to explain kind of how we got to where we are, so everybody understands a little bit of the trouble we had during these negotiations. Obviously, we went through some dramatic changes. You've seen some of the changes already during open enrollment, but what we did from the onset, knowing that there was going to be a lot of changes in the insurance, is what we did is we combined. There were 4 insurance plans between all of the local locations in Arsenal Middle. So one of the things that the company was after, and we were trying to do this for them, is if we combine all 4 of the insurance plans into one plan and one administrator, it saved the company about $8 or $9 million. So what we did is we layered all 4 plans, took the best of each plan, and put them into one plan design. So in other words, we got the best of the best. Like, for example, there's a opt-out clause that was in the ISG plan where you can get $3,600. That was something we grabbed, and then Inland, they had 80/20 copay, we had 90/10, they grabbed that. So we took the best of everything and kind of rolled it together to try to make the best overall plan possible. So on that premise, we're looking to end up with Blue Cross Blue Shield. So we got to that idea and we moved forward with that. We'll talk a little about retiree healthcare changes a little bit. I'm not going to go into a lot of detail with that. I will to whatever degree you guys want. We're going to talk about pensions, the Fine Plan, the SPT, and talk about the changes we went through there. Thinking about retiring, I got some checklists, and I have a second PowerPoint presentation I'll bring up and go through with that. We'll talk a little bit about Social Security and the important information you need to know there. Medicare and some of the changes around Medicare. So changes in healthcare. Active members of 365 retirees will be on the same plan. It stays basically the same with some improvements in plan design. So as of January 1 of 17, UMR will be out as administrator, and the Steelworker Health and Welfare Trust Fund will take over. Community Health Alliance and PHCS will no longer be our network. Instead, we will have Blue Cross Blue Shield through Highmark as both local and nationwide network, a much better network and a much more extensive network both locally and across the country. For Medicare eligible retirees, upon retirement and at age 65 or older, United Healthcare will become the provider for our Medicare Advantage plan. And one of the things I want to talk about is the Medicare Advantage plan. I know I touch on this later on. But one of the reasons we went to Medicare Advantage versus having our current secondary provider is that by going through a Medicare Advantage plan, we were able to save about $23 million a year off of the drain of the VIVA. So by just going to Medicare Advantage through United Healthcare, we kept the same basic plan design, but given the fact that the VIVA was going to be lacking any funding for years 16 and 17, we had to find a way to save some money. And this actually saved us a lot of money. We didn't lose benefit level, but we did have to go through the Advantage plan, and I'll go through that Medicare stuff a little more detail down the road. But that's why we went to the Advantage plan, save some money. Now, what I've done in this presentation, I could have highlighted the entire program, but instead I focused on things that are pertinent and things that changed for us this go around. So now you must sign up for Medicare Part A, even if you're still working. Doesn't mean that Medicare comes into play at all whatsoever with your insurance coverage. What has happened over the years, and we've actually had it happen here, is if you turn 65 and you retire and do not sign up for Medicare and you have a gap in coverage, you will have to pay a penalty for your lifetime. And that's a pretty extensive penalty after you turn age 65. So by having you sign up at 65 while you're working, you avoid any chance of taking that penalty or having that penalty down the road. Now, there is some benefits. You actually could use Part A, which is the hospitalization part of it, and it's the free part of Medicare. You could, given the fact that our insurance costs have gone up, you could actually apply for Medicare to pay for some Part A stuff if indeed you wanted to. So there is some advantage to that, but that's really the only reason we're doing that is so you don't have a gap in coverage from the time you're retired to the time you sign up for Medicare. Pretty substantial penalty. So some definitions that maybe you want to be familiar with is we're not really used to this term allowed fee. We're used to usual and customary or some other associated words like that. But allowed fee is in-network allowed fee is the lesser of the actual charge that a provider, hospital would charge you, or actually the negotiated rate. So that becomes the allowed fee. When you're talking about an out-of-network situation, it will be the negotiated rate, and the plan participants are responsible for the amounts above the allowed fee. So if there's a negotiated rate that is higher than the allowed fee, or the other way around, if the allowed fee is higher than the negotiated rate, you'll have to pay the difference between the negotiated rate and the allowed fee. So you gotta be careful about that. It's the same as the usual customary that we have today. Co-insurance, we're familiar with that because we have once you hit your $250 family deductible, we operate currently under our insurance plan under a 90-10 co-insurance basis. The company pays 90%, we pay the other 10%. That's not really new to us. A co-payment is new to us. That is a fixed upfront dollar amount that you pay for certain covered expenses and does not count towards your deductible. However, it does, the co-insurance and the co-pay do count towards your overall out-of-pocket max for the year, both as an individual and as a family. Deductible is an amount, of course, you must pay each year before the plan begins to pay any or all of your remaining expenses. The out-of-pocket maximum is the amount per person and per family that would be your responsibility. This out-of-pocket max does not include human organ and tissue transplant, co-insurance or co-payments associated with vision, dental, or prescription drug plans. The drug plan has its own out-of-pocket max that we'll go over in some detail later. Change in family status. This is, again, a little bit of different, not a big deal, just so you understand the requirements. You must notify the company within 90 days of a change. For example, if you have a married, divorced, adopt a child, or get legal guardianship of a child as well, you have 90 days to make that notification. Prior to this, you could kind of do whatever you wanted to, but now you have to do it within 90 days. Another change when the plan coverage ends. If you're absent from there, this is a big one, so kind of pay attention to this, because I think our HR lady would probably take full advantage of this. If you are absent from work for a period of 5 or more calendar days for reasons other than disability, layoff, leave of absence, suspension, vacation, jury duty, witness duty, or any other specifically authorized absence, your coverage will end on the 5th day. In other words, get your paperwork in. If you're on short-term disability, if you don't get your paperwork in on time, they could cut you off. Now, obviously, once you turn your paperwork, they'd reinstate you, but that gap in coverage in the meantime could be very costly. For dependent coverage ends at the end of the 6th month following the month in which the employee dies. If you die active, all of your dependents would remain on the active insurance plan for 6 months following the month in which you died active. That's kind of something new. Dependent for us a little bit, but it's changed in some ways. This is a big deal. I put this up there because, as you all probably remember, for the first 4 or 5 months of negotiations, all we were talking about is premiums. What were the premiums going to be? Well, we held firm on that. We sort of drew a line in the sand, said we will not pay premiums. We're not going to do that. We're not paying for insurance as part of our economic package. We're not doing that. There is no monthly cost associated with our active health insurance. This is one of those things they talked about that's new. So there's a waiver of coverage that was part of the ISG plan. It's probably going to be on a rare occasion that this would work. But if you or if your spouse, or maybe you, like Jack, you might have TRICARE, whatever that might work, I don't really know, but there's other insurance you can opt to take. You can take that as long as you and your entire family will be covered under that as primary. You can actually opt out, and the company will give you $3,600 to opt out for each year that you do that. That's someone new. I don't know that it'll happen to me.
That's only an active member? What about
correct? Only active. Only active. So, I'm like John Monsieur, when he was our president, he opted out because his wife had better coverage, so he actually took advantage of that. So there are occasions when it might work. If your spouse has better coverage, that may be a possibility. So I put this up there because there's the issue eligibility spouse both work for the company or are covered by a plan sponsored by the company. You would only be allowed to elect dependent children under one plan. That's changed from the last plan we had. And we had, in a lot of cases, we had salary folks who had insurance, and we had bargaining people who had insurance. They could actually coordinate those benefits. They can't do that anymore. Children under age 26, natural children, stepchildren, legally adopted children, or a child living permanently with you, and your support, and are the child's legal guardian, are eligible. The difference there is that it's identified by saying that you support, and you can prove you support, that's the threshold that we didn't necessarily have before. Handicapped children over age 26 who are deemed physically or mentally handicapped before age 19 and are unable to work and are dependent on you are covered. That's a change from 26 to 19. The determination prior to age 19 is the key there. Any divorce decree that may establish financial responsibilities, the plan would refer to the court decree to determine financial responsibility. There's no change in dependent eligibility. Has anybody, I guess you've seen the multiple emails I sent out about the spousal reimbursement, premiums, whatever. That's kind of a change. It used to be that if you're married about a month before your wife's birthday or spouse's birthday, you would get a letter asking whether or not they had other insurance. If they did, you'd fill out a form saying no other insurance, you'd send it back in. This kind of combines that with the spousal reimbursement form, so that's why it's a little new, and they want to do that during open enrollment, so that they just do all the paperwork all at one time, so that's the way it's going to be going forward, as I'm being told. So if you have not turned this in and have questions about it, let me know, because you haven't since the end of the year. In the event you don't turn in this spousal other insurance form and spousal reimbursement form, there could be a gap in coverage if you don't have it in by January. So if you get it to me next week or so, I get it faxed over, so you're covered. That's, again, a new change. In our current agreement, the first $120 is not covered for spousal reimbursement. Going forward, everything will be covered, including the first $120. Children are not required to be covered by any employer or by law. So if your spouse were to elect to cover them under their plan, and they are primary under their plan, the premiums are 100% reimbursable. We used to have coordination of benefits, but we didn't have reimbursement for the premiums. That's somewhat new. This is redundant there, I forgot about that. So I'm not going to do it here because it didn't work earlier, and I'm not going to screw everything up. But I'm going to send out a different link. We should have our cards. I had a conference call this morning at 10:30. The cards went in the mail today. You're going to see you're going to get two different cards. You're going to get a medical insurance card and you're going to get a prescription drug card. You're going to come in a plain white envelope. On the medical insurance card, there's going to be this link. And now all you have to do is go to Highmark, BlueCrossBlueShield.com, type in your member ID, and you'll be able to search providers, including hospitals, pharmacies, clinics, anything that's in there. I know the way we did it before, you had to go through a series of steps, and it was a little bit confusing, but once you get your card, you'll be able to find whether or not your doctor's in there. Now, what we had done early on was when we were looking for which provider to use, we looked at a bunch of them. We looked at United Healthcare, MetLife, just a bunch of them. We did what's called a disruption report. What you do is you take your current list of doctors that everybody has used in your network and you map it to the doctors that are available in various other networks to make sure that there's not a lot of disruption. That's why they call it a disruption report. In the disruption report for Blue Cross Blue Shield, we lost 7 doctors. One of them is dead now. I think 4 of them are psychiatrists or something. But we gained literally hundreds of doctors and dozens and dozens of facilities. Like anybody who lives in South Bend, like maybe you guys live in South Bend, now St. Joe's part of that. St. Joe will be in our network. That's becoming a very popular place to go. So we actually added a lot of very good hospitals and providers going to Blue Cross Blue Shield, and it's a nationwide network. Even though Highmark is more of a regional thing, Blue Cross Blue Shield, PPO, is a nationwide network, so that's a good thing.
Hey, Todd, does the cards, does your dependents get cards with it?
Yes, everybody will get their own card. And if you for some reason, if you don't get, I just brought this up today, if for some reason you don't get it, say by the next couple of weeks or whatever, let me know, because we can call directly and have one sent out right away. And you can actually print out a paper card too, but everybody, just like we do today, where everybody gets their own card. So there's the number, you have that. So again, there's, I'm going to try to, nobody's happy about where we went. I'm just throwing out there to tell you where we're at. So there was an increase in the deductible from $150 to $200 for the individual, and $250 to $400 for the family. for assistance, we know is waived if you participate in the Health Awareness Initiative. And as of the close of the application period, 7,173 active members participated out of 13,500. That's not a bad turnout, it's pretty good actually, so it's not too bad.
Is that the result that we have to do every year?
Yes, you do it every year, if you want to have it waived. Because the whole argument there, Jim, is that in order to keep our healthcare costs down, you're going to get these exams, you get these, they recommend studies, when you get a colonoscopy. Theoretically, that will keep our insurance costs low, so we want people to get those physicals every year, so, you project when somebody's getting sick. So that's kind of what, remember we used to go in and have they'd come into the auditorium and they'd come into all that, same premise, simply a little more detail. And there's statistics that shows that it doesn't work, so.
Does that program carry over into retirement?
It does until you're 65. Once all the way up to the year you turn 65, you can keep doing that, and you'll actually be able to use that $400 towards your monthly premiums if you so choose. But once you turn 65, the year after that, doesn't help. There's no deductible.
Right.
So. Okay. Blue Cross Blue Shield is a much bigger network. Now, and because of that, the penalty for going out of network has increased. So deductible for an individual is $500 for out of network and $1,000 for family. Co-insurance is 70% now instead of 80%, and your out-of-pocket max for the individual is $2,000 versus $1,500, and $4,000 versus $3,000. So there is a bigger penalty associated with that. But even if you go out of network, that the wellness initiative money could go towards the deductible for out-of-pocket to the tune of $200 and $400. Again, the introduction of copays. If you look at the handouts, one of them is the schedule of benefits. I'm not going to go through everything. And there's also two other, I want you to pay attention to a couple other handouts. You got the 2017 preventative schedule. Again, these are things I'm going to send out via email. This is the stuff that we had before, the preventative stuff that's going to be free. There is no co-payment with that. These are all covered at 100%. And there's also the document called the CDC, Center for Disease Control, recommended immunization charts. That's also stuff that's covered at 100% with no copay. If you don't have that, there should be more copies on the desk. But again, everything I'm handing out today will be sent to you via email, so don't worry, that's going to be the next few days. But all that preventative stuff there is no copay. But for any other normal routine physician visits or a specialist, it's a $20 copay. Then it's covered at 100%. So if you go to your doctor and it's a $140 bill, you pay $20, you're done, and the $120 is paid by the plan. Urgent care facilities, well, let me back up. Spinal manipulation, physical therapy, and speech therapy, $20 copay at 100%. With the spinal manipulation, it's limited to $18 a year. Urgent care facilities, it's a $30 copay, then 100%, which is pretty significant. You go to some of these urgent care facilities or whatever, they're pretty expensive. Emergency room is a $50 copay, and it's waived if you're admitted, then everything's 100% after that. Mental health, radiation therapy, substance abuse for outpatient is a $20 copay, then 100%. So I didn't go through everything, but those are sort of the more average things that people use, more common things. So all other covered benefits are at a 90-10% in-network and 70-30 out-of-network. So if you were to go somewhere, say you have outpatient surgery, you're going to go in, they're not going to charge you anything, they don't know what the negotiated discount rate would be yet, but you'll get an EOB just like you do today, and you'll be responsible for the 10% in that particular facility. And one of the big things that's not up here, I haven't captured this, but I know people in this room, I know a lot of people have this problem, where if they go in for outpatient surgery and the anesthesia was out of network or didn't have a network, there's always that problem. That's fixed now. That is now fixed. They will treat that automatically as if it's in network, and they'll pay it that way. So that was a big deal for us. A lot of people have problems with that. Now, this is where we took the biggest beating by far, no doubt about it. There's no way to walk or step around this. It was huge. So when we first started looking at the combining plans, I'm not saying this to beat anybody up, but bottom line is there was us Inland and the mines were with UMR, and everybody else basically, except research, was with Blue Cross Blue Shield. So we debated for literally weeks and weeks and weeks which way to go. Should we go with UMR, should we go with Blue Cross? UMR is actually a cheaper or less expensive option than Blue Cross is. Blue Cross is a better network, it has better options, it's more nationwide, there's just some better things with that. But in light of saving them $7 or $8 million, when we went to Blue Cross, it didn't save it quite as much, but it was a better deal, and we were quite frankly outnumbered. In the last two contracts, in 2000, let me go back to 2005. In 2005, when ISG became part of ArcelorMittal, they were with Blue Cross, and at that time, the negotiators for the contract were Inland folks, but once we merged with ISG, the ISG folks took over. They wanted us to go to the Steelworker Pension Trust Fund, they wanted us to go to Blue Cross, and when we pointed out to the company that they were paying more on a per-cover dependent basis by going to Blue Cross, they backed off on that. And in 2008, it didn't really become an issue because the big issue back in 2008 was we're making a lot of money, and how do we spread that money around? So nobody really thought about that. This time around, it was entirely about insurance, and we were outnumbered. Once Inland and their 3,000 active and 14,000 retirees, that's 17,000 people covered by UMR, once they walked away and said we're going to the Blue Cross plan, and once the mine said we're going to the Blue Cross plan, the 400 of us and our 100 retirees were left out there in the cold. And I got to tell you, UMR was less than enthusiastic about even talking to us about continuing our relationship. So it is what it is. There's nothing we can really do about that. So we said, okay, we'll go with it. But we told them, look, our deal is, in our mind, 1,000 individual, 2,000 family was our limit. That's as far as we could go. And we sort of drew a line in the sand. Well, as things turned out, obviously it didn't turn out that way. But we went lock, step, and barrel because we had really no choice. So once we decided to go with them, the actuary started figuring out what the actuarial equivalent value of our insurance was across each of the locations. So as you know, with the old plan, when you went to the retail, went to CVS or wherever, got your drugs, if a bottle of pills was $100, you paid the $100, you turned that claim in, and that $100 was reimbursed based on the deductible and the 90/10, and it went towards your out-of-pocket max. Going forward, you're not going to be able to do that. That's going to be a separate copay. That's going to be a separate separate out-of-pocket max. It's not going to count towards your individual and family out-of-pocket max. That was worth 3%. So what all the accountants, the actuary said was that Inland or ISPET was paying 96 cents on the dollar for our insurance. Everybody else is at 93 cents on the dollar. So that was worth 3 cents on the dollar. So we took a 3% hit on our insurance. That's no doubt about it. I'm not going to harsh words with that. So it's a big hit. For 2017, and hopefully for life agreement, Caremark will remain our provider for mail order of prescription drugs. It's a 3-tiered plan, much like we have today. You have your generic equivalent, you have your formulary, which is a drug that's on a list of preferred drugs that is determined by a committee of physicians and pharmacists, primarily done by Caremark. Then you have your non-formulary, or what we consider brand name. You will have a separate prescription drug card to use at retail locations, and you can fill 2 30-day supplies via retail. Then you must use the mail order for the same prescription. Right now you can do it as many times as you want. They're really trying to get you to the mail order. Drugs are almost 18% of our total health insurance cost today. A decade ago, it was less than 8%. It's gone up almost 10 or 12% just in a decade, and it continues to rise out of control. So this is one of the areas they're really focused on because it's where we lose a lot of money, we lose a lot of coverage because of the sheer cost of the drugs. You can fill a mail order refill at CVS, a 90-day supply at any CVS location. We should say, the first question is, are they in our network? Yes, they are. CVS will be in the network, so that's a big help for us. They currently are not.
I thought they said they are going to be.
They are going to be. They currently are not. I think right now all we have is Kroger, Meijer, who else? It's only like 3. Yeah, CVS, the CHA dropped CVS because their costs are so high. One of the things, if you have a smartphone or whatever, I tell people there's a really good app called GoodRx. If you go to GoodRx, put that in your phone, type in any drug there you want, CVS is almost always the highest. But what it does is you type in any kind of drug you want, and it'll tell you all the pharmacies in the area within a 20-mile radius that has that drug, and it'll tell you the price for that. CVS is always one of the highest ones, so that's why CHA dropped them. You can still get them there, but it's the out-of-network rate, which is 20%.